Welcome to our Grand Round series. Our Greenberg Bladder cancer team is grateful you're here. Of course, seeing you in person would be our preference. However, these virtual platforms have proven to be an efficient means for sharing information, for education, and most importantly, for discussion. First, a couple of updates. This is our last session of the semester. Our next semester offerings will be out shortly. We will commence in the new year with a new session entitled, "Is it okay to get a second opinion and change my bladder cancer team?" We're grateful to Dr. Nirmish Singla and our new GBCI nurse navigator, Kristen Tyree, for hosting this. For updated information about the Institute, be sure to simply Google Greenberg Bladder Cancer Institute. Furthermore, I wanted to once again draw your attention to our evolving group of programs, specifically tailored to the experiences of women with bladder cancer, developed and led by Drs. Armine Smith, Jeannie Hoffman-Censits, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. Their programming details, I'm sure, will come up today and also will be available on our website. And of course, please never hesitate to reach out and we will send you the details directly. Of interest, a newsletter will be out shortly and we'll share our important updates with you directly. I'm very grateful to Stephanie Cooper Greenberg for her leadership in developing this for us. Again, all of this information and more is up on our website. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I am incredibly grateful to all of you for joining us today for a session about teamwork in women's bladder cancer, the advantage of the multidisciplinary team. We thought to take a deeper dive into the biology of bladder cancer and talk about what is immunotherapy and how it's important. I encourage you to ask any and all questions. I hope you allow me the chance to introduce our guests today, Drs. Armine Smith and Jeannie Hoffman-Censits. Dr. Hoffman-Censits is Associate Professor of Oncology. As most of you know, she has devoted her career to taking care of patients with bladder and upper tract cancers, and she co-leads the GBCI programs in upper tract cancer with Dr. Nirmish Singla and women's bladder cancer with Dr. Smith. In addition to taking care of patients, she manages an incredible portfolio of novel clinical trials. Dr. Armine Smith is Assistant Professor of Urology and leads urologic oncology at Sibley Memorial Hospital. Along with working alongside Dr. Hoffman-Censits in the women's program, she also leads our translational research program overall at Sibley. We're thrilled to have them join us today. They've agreed to speak for about 30 minutes, and then we'll pivot to a larger group discussion. So I would therefore ask folks to please submit your questions via the chat, and after the conversation, we'll have ample time for open group discussion.
Dr. Armine, you're muted.
Okay. Can you hear me and can you see me okay?
Yes.
Okay, perfect. Okay, well, thank you all very much for having us join and for the ability to talk about teamwork in women's bladder cancer and try to make this as inclusive as possible and address multiple points. And Dr. Hoffman and I will be interchangeably addressing the slides that are on the screen. So why is the teamwork important in women's bladder cancer? I think to get to that point, we just need to go through a few different things. I'll start with the bladder cancer basics. I'm sure most of you know a lot of this, but I just wanted to keep the field level and talk about a little bit of the basics. And then we will go on to speak a little bit about the unique challenges in bladder cancer, about the specifics of bladder cancer in women. And then we're going to switch the gears a little bit and talk about the multidisciplinary care benefits in cancers in general, and then especially with the attention to bladder cancer. So bladder cancer basics. Most of the time, people present to us with the bladder cancer symptoms, including blood in the urine, which is the most kind of predominant symptom that we see in the urology office. Some people also present with pain, urinary burning, frequent urination. There might be a sensation of incomplete emptying of the bladder, and rarely people can see some passage of fragments of tumors in the urine. Basic anatomy, the kidneys are joined with the bladder via the ureters, and they traverse from kind of the upper abdomen, the back of the abdomen, travel all across, and then they join the bladder in the pelvis. Bladder has a unique anatomy in a sense that it has a few kind of distinct anatomical areas that matter to us as urologists and to the rest of the team. But the bladder has the dome, which is the top part. It has the trigone, where the ureters insert into the bladder, and the urethra carries the urine out into the world. The layers of the bladder wall include the inner layer of the urothelial lining. It includes a few layers of these cells that are kind of piled up on top of each other. There's a lamina propria right under it. There is the thick muscle layer because the bladder has to cycle through multiple contractions throughout the day. And then the outer layer is the fat of the adventitia of the bladder. Now, looking at the kidneys, we have the kidney parenchyma, which is the outer lining of the kidney. We have the inner passage of the urine that's collected into the renal pelvis and then carried down through the ureter. And the renal pelvis and the ureter are lined pretty much by the same cells that line the bladder and can develop the same types of cancers as the bladder. Speaking about the bladder cancer stages and grades, in general, the bladder cancer or the typical bladder cancer rises in the urothelial lining of the bladder, which is the inner part. It can form as flat tumors that are CIS. It can become more papillary and more invasive. So the TA is usually contained within the urothelial layer. T1 can penetrate into the lamina propria. T2 goes into the muscle, and T3 is a little bit more advanced. And as the stage progresses, we usually, these treatments demand more radical approaches. On the left, the only reason I have this illustration just to show that the papillary tumors and the flat tumors can both have this architecture. It doesn't really have a huge implication for the treatment, but something that can be seen in the pathology reports and can be confusing to people. But it's kind of just the architecture and the formation of the tumors. On the other hand, when we look at and we talk about the bladder cancer, we refer to it as low grade or high grade. So going from normal urothelial layer, low grade, it just under the microscope looks differently, and the high grade has more aggressive features on a microscope. We also have different mutations and things like that associated with them, but that's a conversation for a different day. Dr. Hoffman?
Sure. So this just reminds us that the majority of patients with bladder cancer actually have tumor only in their bladder, and in fact, a tumor that is non-invasive. And so, although we're talking about multidisciplinary care today, in fact, the majority of patients with bladder cancer are seen only by urologists. And that's because the role of a medical oncologist or a radiation oncologist or other specialists outside of a primary care physician are fortunately somewhat limited. Some of our newer medications like immunotherapy are starting to be used in the localized setting. We actually have a physician on campus, Dr. Han, who's a medical oncologist, who's using oral medications or thinking about IV medications in this space in clinical trial setting. But for the most part, a patient with bladder cancer is likely to be seeing a urologist only, which is appropriate. And then as cancers become more high grade, aggressive and complex in the locally advanced and metastatic setting is where the team can become more multidisciplinary.
I'm going to advance to the next slide. So bladder cancer as a cancer itself has unique challenges. And most of these come from just the patient's demographics that we see. Usually this is a disease of older patients. I would say probably the average age is about 70s or so, although by all means, younger patients get it as well. A lot of the times the patients we see are malnourished and they have muscle wasting, sometimes called sarcopenia, which is another measurement of the body wasting. This can be because of the cancer itself, because of the advanced age, because of the other medical issues that go hand in hand with with the older age. Some of the patients that we see are deconditioned, and again, this can be because of the treatments, because of the cancer itself, or the lifestyle, and a variety of issues. Some of the patients have decreased renal function, which matters a lot, and both the ability to recover from the treatments, from our ability to give treatments of certain kind. Some of the issues that Dr. Hoffman deals with are the hearing issues and neuropathy that can affect patients' ability to receive chemotherapy if needed, and in general, kind of the frailty and ability to cope with the treatments. A lot of the bladder cancer patients, not all of them are smokers, and that has its own kind of separate issue with the pulmonary status, the COPD, and the ability of the lungs to go again through very challenging treatments. Now, speaking of the treatments over and over, the treatments can be demanding for bladder cancer. So if you remember one of the earlier slides, the arrow pointing to the right. So the more invasive the cancer becomes, the treatments become more invasive. And, some of the most radical treatments we do is removing the bladder, or radical cystectomy, and then systemic chemotherapy that goes in the multidisciplinary approach, kind of basics of the bladder cancer, is one of these treatments as well. And Dr. Hoffman, do you have anything to say?
No, it's I think you really covered it well. The majority of a lot of these issues that concern us come as the tumor becomes more aggressive and advanced, and therefore the choices that we need to make regarding systemic therapy, which at this point has a lot of both short and long-term toxicities, becomes more challenging. But these are some of the things that we think about as we make those decisions.
Yeah, so moving on to the surgery itself, the radical cystectomy is one of the more challenging surgeries we do in urology. Has a fairly kind of a sad looking portfolio. The perioperative morbidity, which means the rates of readmissions and other medical issues that happen after surgery, is about 60%. So there is 60% risk of person who had a surgery will end up with some kind of complication. And the rates of even kind of dying around the surgical 90-day mortality, kind of the period, is about 5 to 10% reported in literature. On the top of it, with the radical surgery, we have older and frail surgical patients, which experience increased mortality just because of the frailty, increased length of stay in the hospital and readmissions. And again, because of all of this, there can be more potential for adverse effects and loss of functional status. There are some alternatives to cystectomy, and some of those are more effective than other. Usually, again, the more kind of effort we put and more treatments we throw at the patient, the more effective it is a lot of the times. So other than removing the bladder, the trimodality organ preservation is shown to be fairly effective. Sometimes we can skip the radiation and give chemo and still do organ preservation. And then there are some single modality treatments that are kind of on their own are less effective than more radical approaches. Now, trimodality treatment, what it actually is a resection of the bladder tumor to the maximum, and then addition of chemo and the radiation to the pelvis and the bladder. And so it's a combination of 3 different modalities. With the proper patient selection, we have seen a similar survival to radical cystectomy, which is fairly appealing. The question is, we still don't know who's a very good candidate for this and who's going to do well with it. And these are some questions for the future. And there are some active trials that are looking at these questions and trying to answer them. Moving on to bladder cancer in women has its own kind of a set of interesting challenges. And bladder cancer is mostly a cancer of men. So if you look at all the kind of cancers and incidence in the US, it's about the fourth from the top cancer in incidence and number 8 cancer in its mortality potential. It doesn't make it to the top 10 for women. So there are some sex disparities in bladder cancer, and we still don't know exactly what the precise cause of it, but there is, I think it's a combination of a few factors. One of these numbers is kind of on the bottom of the page, so I don't know if you can see it well, but men usually develop bladder cancer 3 times more than women. So the ratio is 3.3 to 1. But women die more of the bladder cancer than men do. So the cancer-specific mortality is about 19% in men and 25% in women. Some of the factors that we think are important in this is later diagnosis in men versus in women versus men. Usually, if you look at certain studies, there is a diagnosis lag by about a month or so. And that has to do with, a man feels a symptom, they go to the urologist, and the woman, when they have a symptom that can be associated with a bladder cancer, end up in this kind of a whirlwind of, going to minute clinic, getting antibiotics, maybe seeing a primary care physician, getting antibiotics or GYN. And then eventually, once it's tried a few times and, it doesn't work, they end up in the urologist's office. So this causes a delay. Some other things that we know that are important, and I don't know, Jeannie, if you had anything else to say about this slide before I move on to the staging.
No, I don't think so. This is just one example, but there are a couple different studies, as you mentioned, that recapitulate this, this notion that that women will be more likely treated for a urologic symptom by a non-urologist for a longer period of time, including antibiotic therapy, prior to be referred to a urologist. But as you mentioned, and we think that's just kind of one of the issues that leads to this increased morbidity and mortality in women.
Mm-hmm. Some other issue that I wanted to bring up that we see fairly routinely as the quality of staging. So the staging for bladder cancer a lot of the times is done by removing the tumor, resecting deep enough to see the penetration of the tumor. Oh, sorry, my window just closed. Wasim, do you want to switch to your PowerPoint slide?
Sure. Which slide? What was the slide number?
I think it was maybe 12 or 13.
Okay. I don't see the slide numbers.
Okay, I'll just tell you when to stop. So it was a slide called staging.
Do you see my screen?
Yep, I see your screen.
Okay.
Keep going, keep going.
Okay, keep going up or down?
Forward. Forward. More forward, maybe 2 more slides. Keep going forward. Keep going. 1 more. Okay, so can you click again?
Okay.
Yeah, so the quality of staging really depends on the proper, depth of the resection, so we can see how deep the tumor has grown, because that changes a lot of the paradigms in the treatment that we do. So we know for a fact that the outcomes are worse when there is no muscle in the specimen, and whether this is, really the undertreatment or the reflection of the quality of the treatment and the treating team, it's probably a combination of both. Can you click again? We do know that, looking at these scientific papers, that when the muscle is absent and when it's not mentioned in the pathology specimen, people do worse with it. And interestingly enough, we know that women, because the bladder is thinner, end up with more of these inadequate bladder cancer specimens that are reviewed. So I think that might be one of the contributory factors as well. Next, please. Another topic that I think comes into play when we talk about the teamwork and women and addressing bladder cancer in women is the quality of life survivorship issues. Interestingly enough, up to maybe 5 years ago, these were really just non-existent studies about the how women do after the treatments. When we started looking more into this, we've picked up a lot more psychosocial issues and sexual dysfunction in women that was previously identified. Next, please. Especially the sexual dysfunction after radical cystectomy, there are anatomical factors, there are disruption of nerves to the clitoris, there is changes in anatomy, there are hormonal changes because the removal of the ovaries. And interestingly enough, the more we ask women, the more we find out that the provider-led discussions are really lacking. So women are not getting the education and the knowledge that they need. Next, please. So, some of the, providers may think sexual, function is not as important in postmenopausal women and older women, but we know that's not the case. Next, please. So why are things different for women versus men? So looking at the slide, male cystectomy or removal of the bladder is different because the organs in the pelvis are obviously different. In men, we remove the bladder. Sometimes we remove the prostate with seminal vesicles, or I should rather say most of the time. And then we remove the pelvic lymph nodes. In females, there is a bladder. A lot of the times the uterus and the cervix that are sitting adjacent to the bladder are removed. Ovaries, because they're kind of sitting in that same area. And so just a bladder up here, uterus up here, ovaries are removed as well. Anterior vaginal wall that is adjacent to the bladder or the posterior bladder wall, that is also removed sometimes appropriately, sometimes not. And then urethra, which is kind of that short tube between the bladder and the perineum, can be removed as well by some urologists. And then we have the pelvic lymph nodes as well. Next, please. What we have learned that we can spare pelvic organs in women, and it's a safe approach, and it preserves the oncological outcomes, so people don't die of cancer and they don't have worse kind of return of cancer when these organs are spared. And we know that functional outcomes are better in women who have these organs spared. About 40% of providers, unfortunately, don't even inform the patients of the possibility of the pelvic organ sparing cystectomy. Next, please. What we probably do better now, and we should focus on, and I think that also comes into the multidisciplinary discussion and plays into this the idea is better educational initiatives for women. We want to have more pre-treatment counseling with the provider. We know there's a benefit from that, benefits from support care groups, educational series, patient-to-patient blogs, which are available in the on the media and with the institutional resources as well. Next, please. We do have another educational initiative that was just started here, and that is the study of gender-related coping and survivorship. So we are going to look at the educational interventions prior to treatment of bladder cancer and assess the effects of coping and the post-treatment sexual dysfunction. Again, this, I think, comes together as a team approach and a multidisciplinary approach. Next, please. So with this being said, we can transition into speaking more about the multidisciplinary care benefits in cancers in general, and then bladder cancer in particular. So what is the multidisciplinary care? It is, the whole initiative is of coordinated, evidence-based care when multiple treatments are available, such as in bladder cancer. What we know is that they promote shared decision-making between the providers and the patients. And we know that these initiatives help tailor treatment to patients' unique values and preferences, superimposed on the evidence-based treatments. Next. There have been multiple studies that addressed multidisciplinary care in different cancers. The closest probably cancer to the bladder is the prostate cancer, just because it's a genitourinary cancer. So what we've seen is that this has become a standard of care in multiple institutions. We have seen changes in management when patients are seen by the multidisciplinary team. It reduces the bias, increases the evidence of evidence-based guidelines. I feel like, the team members keep each other in check. You have multiple kind of input from multiple specialties. This also improves the clinical outcomes, and it definitely increases efficiency of the treatment that's delivered and diagnosis and tissue testing, because it minimizes the time that the patient has to spend in the medical system trying to get the diagnosis and the treatment plan. Next, please. So what is the multidisciplinary care in bladder cancer? Next. We have multitude of people that can be very productive and part of the multidisciplinary team and have specific roles in there. So the core usually is composed of urologists, radiation oncologists, and a medical oncologist. We also include the genitourinary pathologists because we know when the pathology is reviewed by a specialized kind of genitourinary pathologist at the high level of tertiary care center, a lot of times there is a reclassification of the diagnosis up to about 30%. The radiation team also includes the radiologist and interventional radiologist who look through all the available studies and discuss in a multidisciplinary approach. Physical therapy becomes very important, and especially patients that are older and deconditioned. We have the pre-habilitation, rehabilitation after the treatments. Dietitians are also, increasingly became more important as we learn about the malnutrition in the patients, about, the immune benefits of nutritional supplementation, et cetera. Because a lot of the bladder cancer patients develop symptoms, whether it's urinary tract symptoms and some pain control. Pain team may not be kind of on site and present, but at the short distance where we can reach them, and having integrative care ability is fairly important for a lot of the patients. We do resort a lot of time to social workers for psychosocial challenges, for coping assessments with the difficulty to getting to treatments, and just in general kind of coordination of care. Here at Sibley and a lot of the places that deal with the geriatric population, there is something that's called the PRIME team. That includes anesthesiologists, the surgeon, again, social worker, physical therapist, geriatric nurses. And these are the teams that optimize the older and frail patients for major surgery. And we do also involve the clinical trial staff, which is ideal for screening, data collection, and ability to enroll the patients into the clinical trial. Jeannie, do you have anything to add to the slide?
No, I think one of the important things is that there's a lot of these invisible team members that, as a patient, you may wind up seeing maybe just the two of us, if we're involved in your care at Sibley together, but we really do sometimes by email, by telephone call, by, messaging through the Epic system, work with all these different team members. And I'm sure there's some that we missed, based on the individual patient. I think primary care physicians are also kind of important here, of course. We talked about that last week, a week ago, 2 weeks ago. So there's so many people that kind of come in and out kind of based on the need at the time. And many of whom, it's a shame, the patient doesn't even recognize or are involved in kind of thinking about the best practice for their care.
Okay, next slide, please.
So I think one of the team members that's hugely important, and I think we probably interact with more than most, is the pathologist. We have some really fantastic pathologists here in the Hopkins system, and I think one of the slides that Dr. Smith showed earlier about the, whether or not there's muscle in the transurethral resection specimen, that can have an impact on someone's prognosis. But it's not just the care and the skill of the surgeon; it's actually the pathologist who recognizes what's the best practice to report out a biopsy specimen of a bladder and to inform the urologist if something is not adequate, and then a specimen has to be repeated. The majority of bladder cancers are urothelial cancer. That's the top left. But we do see, because we're a tertiary care center and we do see a lot of patients with urothelial cancer or bladder cancer, we do see these and other variant histologies. And as you can see, they look very different under the microscope. So it's important that our pathologists are kind of watching out for this. But the reason that's important is because they also behave differently. And at least for small cell, it indicates a different kind of plan for treatment. For squamous cell carcinomas, a few of us a few years back kind of recognized that more of our female patients have squamous cell carcinomas. In fact, there's one of the urologists named Sunil Patel who's looking into this, just trying to better understand kind of why this happens and some of the outcomes from pre or post-operative chemotherapy in that population, particularly of women that tend to get that, what we call variant histology. So our pathologists are really integral team members that you'll never see walk into the office.
Next, please.
So if you can click the next slide, please. So in patients, and you can just kind of keep clicking down the list. I didn't realize this was animated, sorry. And then kind of keep it here. So for patients that have muscle invasive bladder cancer or lymph node positive bladder cancer or upper tract urothelial cancer, that's when a medical oncologist is most often getting involved in someone's care and then making decisions about, whether or not this would be a patient that would be fit to defer a surgery with curative intent in order to give chemotherapy first. So, Dr. Smith and I kind of seamlessly worked through this conversation with, referrals, discussions, treatment, and referrals back, based on whether or not we feel like someone can tolerate the side effects of this medication. We're focused on this medication because it's the only one that improves overall survival for patients with muscle invasive bladder cancer, with the ultimate plan is for them to go on to surgery. And so it's important for us to determine whether or not it's appropriate for someone to receive this medication preoperatively. Next slide. So if you kind of click down this one as well. So there's some things that we can think about that may be in someone's medical history or may be related to their anatomy that we can use our other multidisciplinary team members to help us enhance someone's eligibility to receive cisplatin. So if a patient, is seen by urology and gets restaging scans and it looks like their tumor is obstructing or blocking the flow of one of their kidneys between, initial evaluation and follow-up prior to chemo, then that patient maybe can have a follow-up TURBT and a stent placed by Dr. Smith or their urologist. We can ask interventional radiology to do something called a percutaneous nephrectomy, which is the same idea to kind of unload the plumbing of a blocked kidney, but to do it through the skin and out the back. That's a temporary solution, but that helps us get patients through chemotherapy. And we do that through, working with our interventional radiology department. We work with cardiologists as well as sometimes nephrologists and other team members to do additional measurements of kidney function and even change medications that can impact chemotherapy eligibility in order to enhance and optimize someone's kidney function prior to surgery. So again, not for everybody, but for some, these additional team members are really important in the pre-operative setting. Next slide. And I know we talk about clinical trials. These are the different what we call phases of clinical trials, and the team members that that we bring in. So at Hopkins, we run all of these different clinical trials, which may or may not be available or appropriate depending on someone's stage of their cancer. But for each person that comes into the office, we're thinking about their eligibility and fitness as well as availability for clinical trials. So we actually just before this meeting have a clinical trial meeting with our entire staff where we go over the new patients that we've seen during the week and just get a sense of whether or not they may be a candidate for some of our clinical trials. These range from novel drugs that are not FDA approved and may or may not have been given to a lot of patients to large kind of post-approval studies. We're trying to get more information about an FDA approved drug. Next slide.
So I thought this would be pretty interesting, and I only have a couple of slides. I know we're going a little bit over time, but just to illustrate, how multidisciplinary care, like in a very specific setting, improves the outcomes. Next. So I came across this as I was looking through the literature. This was a program that was in Brazil, and they subdivided patients into 2 different groups. So one group, patients were just treated with standard of care for their bladder cancer. And the group 2 of the patients were referred to centralized bladder cancer program that incorporated multidisciplinary care. Next. So the design of it was that the group 2, so the patients that had the centralized care, had their care discussed by a medical board composed of urologists, oncologists, radiation oncologists, kind of like what we've discussed earlier. They also had some additional measures. There were some smoking cessation referrals. Patients who had low blood counts or anemia were treated with different interventions, reducing demand for blood transfusion. The malnourished patients were referred to a dietitian and given nutrition supplementation. There was a unified team that operated on all the patients, had kind of fast-tracked, enhanced recovery pathways, and this was just very consistent for the group 2. Next. And the results were pretty striking. So in group 1, the only treatment that patients received was actual removal of the bladder. In group 2, about half of the patients had treatment that included removal of the bladder, but about 5% received partial cystectomies, which is only a partial removal of the bladder wall. 12% received bladder preservation with trimodality. 22 patients received palliative chemotherapy. So these would be the patients who would have gotten unnecessary surgery. And another 5% only had just transurethral resection of the bladder tumor. No patient in the first group received neoadjuvant chemotherapy, whereas it was offered to a majority of the patients that were treated with radical cystectomy in group 2. 90-day mortality rates were higher in group 1, and that was both long-term and short-term finding, which I thought this was just a very striking example, and you can kind of see how this makes a difference in patients. Next, please. All right, Dr. Hoffman.
Yeah, so in summary, we really feel like the care of patients with bladder cancer is often done in a multidisciplinary format. As we said, it kind of depends on the grade and the stage and the complexity of the cancer and the patient with that cancer. This format really expands, particularly at academic centers. We have people that kind of think about this all the time, and centers of excellence where we see a lot of patients that have bladder cancer, and again, increased by the need and the higher grade and stage. I feel like we kind of crowdsource with our different levels of expertise based on this. Women with bladder cancer have, a unique history, often come to us with, some delays or other challenges related to their bladder cancer. And again, it may be best served in this multidisciplinary setting. Next slide. And these are just, this is some of our multidisciplinary team. Here, of course, we have the Greenbergs who really have helped to build this program. Dr. McConkey and Dr. Hahn are kind of scientific and clinical director. We have surgeons, pathologists, radiation oncologists, basic scientists on this slide, all working together in concert to make the lives of our patients with bladder cancer better. Thanks so much for your attention.
Thank you. Maybe time for questions.
I'd like to thank both of you for doing that, and also just reinforce the fact that the multidisciplinary clinics give us the best opportunity to integrate our patients into our research programs. So we're intentionally building our research programs on the backs of the hard work that Jeannie and Armine and the other investigators involved in our MDCs are doing clinically. So I have a question for you. Armine, you talked about the differences in incidence between men and women. Can you elaborate a little bit on that? What do you think might be the causes of that difference?
Again, we don't know it yet. We think it can be a combination of some genetics, combination of environmental exposures, protection from bacterial microbiomes in women, and some hormonal changes. I think there are other ways that women metabolize the environmental kind of exposures that are different than men do. So the incidence is much lower in women, but curiously enough, when women get it, they get it worse, or at least they're diagnosed later and treated later.
Yeah, there's some preclinical studies that suggest that there are direct roles for estrogen receptors and testosterone receptors. And so I think that's an area of research that really deserves further attention. So what would you recommend to community programs for MDC? I feel like so many of the community urologists are used to flying solo.
Yeah, I think I can probably tackle that one since it goes down the urology pipeline. It's unfortunate, the problem with not having a team nearby is the ability to communicate effectively and get in patients to these multidisciplinary settings easily. The beauty of having multidisciplinary academic practices where everybody's at a phone call away or an email away, or the ability to at least have some virtual kind of multidisciplinary care without having the patient in the same space as multiple specialists. And I think, you just have to find a practice in the community that has a good interaction with the medical oncology and the radiation oncology, and the ability to have these conversations. And when things get complicated, get a second opinion. I think that's probably the easiest thing to do.
So
I completely agree. I think the other thing, I think to be fair, is that the multidisciplinary approach might not look like 2 people or 3 people or 4 people standing in front of a patient at the same time. It's actually rare to see that. There's some clinics that have that set up, but the efficiency of doing that creates really a lot of unique challenges. So it may very well be that urologists are engaging with those other disciplines and maybe not being so forthcoming about it. There are things like tumor boards that happen at every cancer center. They look different at different places, but it may be that virtually, there's a conversation around new patients being seen in urology practice that are including medical oncology, that are including radiation oncology. And again, I think because that's to some extent a part of our normal routine, that might not be something that is conveyed as well as it could be to the patient. So what multidisciplinary looks like can be very different in different places.
Yeah, I guess not to sound too critical, but a lot of our patients come in through urology, and it's difficult, I guess, for some practices to consider alternatives to surgery for clinical management of these patients. So one of the big changes that's happened over the last few years is that some of our urologists are taking active roles in proposing and supporting bladder preservation with trimodal therapy. Certainly that's done a lot here at Hopkins. It's also being done more across the country. And I think a big part of that is that urologists are leading those conversations. So I think, again, it's really important for patients to have advocates who can help ask questions and challenge answers along the way to make sure that the care that they're receiving is optimized. So is there more research being done on gender differences and outcomes in bladder cancer? Is this now being looked at?
I think the answer is yes. In addition to us, there's other kind of teams across the country that are doing this. I think, Dr. McConkey, as you mentioned, there are some and Dr. Smith, some changes, some mutations that we see, more frequently. There's these different subtypes of bladder cancer that you were kind of an architect of discovering, and we can see that bladder cancers can sometimes fall along these different, almost like brands or lines, and that women tend to get certain types more than men. So it may not, I guess, be branded as much in terms of this is how we treat women's bladder cancer and this is how we treat men's bladder cancer. But I think what we are doing is really understanding the biology of all individual bladder cancers and then treating patients more in a targeted kind of fashion based on their individual kind of tumor. And from that, I think we're therefore treating patients and thinking about patients more across those gender specific lines. Like I mentioned, for instance, we know that patients with squamous, bladder cancer, take all of them. The majority, or at least half, are going to be women. That's not our normal ratio. And so, I was having a conversation with a sponsor, a pharmaceutical company the other day, just talking about, how can we think more about different subtypes of bladder cancer, particularly women, and we really were kind of talking about that you may want to think about the kinds of specific tumors that women may get, and that you may be understanding both a subtype and a gender issue at the same time.
Thanks, Jeannie. Armine, did you want to say anything?
Yeah, I think, it's interesting how things have changed over the past maybe 10, 15 years, going from very little research on bladder cancer to a lot more research studies, and now addressing the gender-based differences on both molecular level and quality of life outcome levels. I think, the field has taken off in that sense. So there's a lot of research being done, yes.
Yeah, what's remarkable to me, and maybe fortunate, is that we have mice who get bladder cancer when we expose them to a cigarette smoke carcinogen, and we get kind of the same difference in ratio of tumors and tumor genesis in the mice as we see in people. It's always kind of a leap to go from mouse to person, but it may be that we can use some of these mouse models to understand why there's this difference that we see in both mice and humans. So I mentioned that patients who are seen in the Multi-D clinic also contribute to the GBCI's research program. Can I elaborate? Yeah, I'd be pleased to. So I guess the fair thing to say is that because Jeannie and Nirmish and other members of our upper track program were successful in recruiting in a patient navigator, and now we have a clinical data coordinator who's an MD, we have now a pathway for patients to be identified coming into the MDC and consented for research, which is really important. Not everybody wants to participate in research programs, so we have to do a formal consent both for clinical data collection and any sequencing or other things we might do to their tissues. And then that's handed off to our research team. So we have a lockdown, what we call a REDCap database, where we're collecting upper tract patient data prospectively. And so we had to get all the personnel in place to do all of that, which wasn't insignificant. And so we also now have a model for how to do this in the women's program and other multidisciplinary clinics across our institute. And what this all boils down to is that we understand the need to collect high quality data of all sorts in real time. Because when we do it after the fact, then elements are missing. We don't have as much opportunity to quality check. So by having the clinical infrastructure in place of the multidisciplinary clinic, we now know which patients are coming in, when they're coming in, we get them consented, and we know their tissues coming in. And in some cases, with some of our patients, we'll have novel things that we want to do that need things like urine collections and blood collections and so forth. And all that can be coordinated between the clinical and the research teams. So another question is, what organs are typically spared for women during radical cystectomy?
typically, going back, usually none of the organs were spared for women during radical cystectomy. We have, fortunately, have learned to step away from this dogmatic approach. So depending on the type of cancer and the location of the cancer and stage and kind of the radiographic characteristics, we know that uterus can be certainly spared. The ovaries can be spared. What becomes a little bit tricky, preservation of the vaginal wall, anterior vaginal wall, that has a lot of consequences for women for kind of sexual activity afterwards. And then, patients who have, let's say, big or invasive tumors in the back of the bladder, the posterior wall of the bladder, sometimes they can penetrate into the vaginal wall, and the vaginal wall still needs to be taken. So that's a little bit of a kind of a tricky decision to make. But essentially, if the cancer is not invasive or it's located in a favorable position, we can probably pretty much spare all the pelvic organs, which is, as I said, important for functional outcomes, for anatomical and sexual function, and for pelvic support.
Can Dr. Smith and Hoffman-Censits comment on women being diagnosed with bladder cancer late and often missed? How can gynecologists and urologists work more closely together to avoid this delay in diagnosis? And what needs to change in the system?
I guess I can start and then Dr. Hoffman can join. But I think this is kind of the million-dollar question. And I feel like we've been kind of dealing with this. And the problem with this is the criteria for workup for bladder cancer or for referral to urologists are different in different societies. So the Gynecology Society usually has a higher threshold of more red blood cells per urine at which they recommend doing further investigation. In urologists, we have less, and it has to do with patient groups. So they see younger and more like typically healthy patient population, and we see more kind of a biased population who has the propensity to form cancers. So I think that is one of the issues. The other thing is, it just really has to be on the top of the list for the specialist to think about it. And the rule of the thumb is if there are unexplained urinary symptoms, unexplained blood in the urine, that requires a referral to urologist. And hopefully from the advocacy, from the education and these blogs and trying to disseminate this information, this will become more widely accepted in just general medical community, not just urologists.
So there are urologists that we work with who are trying to democratize things like cystoscopy and TURBT, taking images as they're doing cystoscopies and thinking about using things like machine learning to identify features that may be more or less obvious to a given urologist. Bert Vogelstein here and also the NCI in general are interested in developing tests that would be more or less routine. You go into your primary care physician every year, you get a blood test, and you get a multi-cancer detection system in place to tell you what kind of cancer you might be harboring in an early detection setting. We're working with people who are very aggressively developing the same kinds of tests in urine. I mean, these are right now kind of futuristic ideas, but to me, it seems like if we could get tests that are easier to diagnose urothelial cancers, we would have better outcomes. And part of that, I think, is going to be leveraging some of the really exciting work that's coming out with liquid biopsies, which we're going to be talking about in the new year. So any other questions from the audience? I guess maybe in kind of closing, can you both comment on the importance of navigation and having navigators for the kinds of programs that you're assembling?
Sure, I can take this one. When we're incredibly lucky at Sibley, the site there, to have Patient navigators, I think, getting a diagnosis of cancer and all of the things that go along with, thinking about staging, thinking about referrals, the timing, laboratory studies, location of these tests. It's someone's going through the worst and scariest thing that they may have ever been through. And then on top of that, having to navigate a healthcare system that they may be unfamiliar with, that they're coming, from a tertiary care system that they're afraid of. I mean, there's so many different things. And so that initial time when you're going through workup, biopsies, follow-up information, of course, navigating our MyChart system, all those things, and the emotional toll all that takes, it's like, it feels so disorganized, and for each person, it's going to be different. And so to have someone who, you can always reach out to and say, ours is named Cynthia, Cynthia, what happens next? Who am I supposed to call about this problem? Or, when is this appointment? What happens next? I think has been just so vital. And we're hoping to have more of those folks in place. I think that those that have met and worked with navigators, I think have really gotten a benefit from them.
Thanks, Jeannie. So we have a statement and a question, I guess. How can one be seen in the MDC clinic with these two amazing clinicians? And thank you for being the first women-only clinic. So anytime you want to come, just email us at bladdercancer@jhmi.edu. And you're also welcome to contact us by telephone if you have our telephone number. Just reach out. And another question, you may have mentioned this, but is UTUC more common in women?
I'll take that one. It's not more common in women. In terms of outcomes, men versus women, I think it's a little harder to tease out the tumors in the upper tract compared to bladder cancer because of some unique challenges with staging as well as aggressive biology, tend to have different and worse prognosis. But I don't necessarily think that the outcomes are worse. I do unfortunately think because the presentation is the same, which is, essentially blood in the urine, urinary symptoms, that there can also be a diagnosis delay. But because upper tract urothelial cancer is pretty rare compared to bladder cancer, it's about 5 to 8% maybe of all urothelial cancers every year. The data aren't not as kind of robust in that arena. But it's a great question.
So I wanted to pitch, in closing, the sex-based differences that both Jeannie and Armine are studying in the patients at Sibley, where they're actually doing a very exciting study on the microbiome and response to BCG. So again, I think thanks to both of you for your effort in creating this fantastic program, this fantastic MDC, and look forward to watching this take off further. Any final questions in closing? Here's one. Does Hopkins have a peer-to-peer support program for bladder cancer? The answer to that is we do have a women's program. I would say we've been sensitive to not step on the toes of Beacon, who've got a lot of peer-to-peer programs available. But we definitely have a specialized group focused on women.
And I think I'll add on to it. So the peer-to-peer support, I think, is very important in the setting of radical cystectomy. So I end up being the person who kind of refers the patients to this the most. And I think, we do have a kind of a group of patients that are available for that. And I also try to kind of use my own patients as peer-to-peer patients that, let's say, are being treated by me. So I think it's very important. I think, yes, we have it, and just ask, we'll get you, we'll get you in.
Well, thanks to both of you and all of you for joining us today. Have a great holiday season, and hopefully we'll see you again in the new year.
Thank you. Happy holidays, everybody. This was a pleasure.
Thanks, everybody.